Welcome back to the deep dive. You know that feeling when you look at an anatomical diagram and realize one small space is the functional intersection of the entire head and neck?
Oh, yeah.
Today, we are strapping in for what might be the ultimate anatomical challenge. We're diving deep into the most dense and, let's face it, surgically unforgiving regions beneath the skull, the infratemporal fossa, or ITF, and its crucial medial neighbor, the Pterygopalatine Fossa, the PPF.
Yeah, historically, these spots, they've really been the bane of surgeons, haven't they? These sort of dark, inaccessible corners behind the maxilla.
Right.
Their complexity, how hard they are to get to, and just how close they are to absolutely vital structures. Nerves, the big arteries like the internal carotid. It kept clinicians wary for a long time, really restricted the options.
But that's changed now, hasn't it?
Yeah.
The game has fundamentally shifted.
It really has. Advances in imaging, CT, MRI, and crucially, the rise of endoscopic techniques, skull-based surgery.
Yeah.
We can now access these spaces with, honestly, incredible precision, but, and this is the big but,
Okay.
this access demands something far beyond just, textbook knowledge. It requires total three-dimensional mastery. You have to see it in your head.
And that's our mission today, right? Total mastery.
That's the goal. Whether you're listening as a maxillofacial surgeon planning a tricky excision, maybe a neurosurgeon dealing with a skull-based tumor, or an otolaryngologist approaching the nasopharynx, you just have to know this anatomy cold, period.
So we're going to systematically break it down. Boundaries, contents, the surgical guides, the hazards, everything you need for that elite professional shortcut to really owning this anatomy.
Exactly.
So let's first frame the surgical context. Why exactly are surgeons going into these incredibly tight spaces? Our sources seem to boil it down to four main reasons.
Yeah, that's a good summary. Primarily, it's about dealing with pathology, right? So that could mean just getting a quick biopsy to figure out what's going on.
Diagnosis.
Or doing a partial or selective excision if it's something localized and hopefully benign. Then, of course, for malignancy, you're looking at total clearance, maybe a full compartment resection, getting everything out.
Right. Much more aggressive.
Much more. And the fourth reason, which sometimes gets overlooked, is that these fossas, they're actually a necessary route or corridor. You have to pass through them to get to deeper stuff at the skull base.
Like near the cavernous sinus or the petrous apex.
Precisely.
Yeah.
Sometimes the ITF or PPF isn't the target itself, it's just the highway to get there.
And the approaches reflect this sort of dual world of modern surgery, don't they? The big traditional open view versus the minimally invasive keyhole endoscopic route.
Exactly. You've got the classic open approaches coming in from the side, the lateral approach through the temporal or mandibular areas, or anterior through the maxilla, sometimes inferior, superior. Often you combine them depending on where the tumor's going.
Right.
But the real revolution, I think we'd agree, has been the minimally invasive endoscopic approaches, especially endonasal, going through the nose. Also transmaxillary, transpterygoid, various ways in. But here's the key thing for mastery. The anatomy doesn't change.
Right. Same structures.
Same structures, but the view is completely different. So the elite professional needs to be fluent in recognizing everything from these, drastically different perspectives. It's a whole different mental map.
Okay, let's unpack the infratemporal fossa first.
Yep.
The IPF. So geographically, where are we? It's lateral, deep to the ramus of the mandible,
Behind the maxilla.
and below the middle cranial fossa. It sounds complicated just describing it because it's really a space defined by what's around it, not like a neat box with walls.
That's a really crucial insight. It's not a contained room. And our sources really stress that there's actually a lack of consensus in the surgical literature on the exact boundaries.
Oh, really? Okay.
Yeah, so when we talk about the ITF, we're generally focusing on the, let's call it the conventional description, the sort of surgical definition that actually guides how you dissect.
Got it. So let's try and nail down the superior boundary then, the roof. It's called infratemporal, but what actually forms that roof? It's a bit counterintuitive.
It is. It's quite misleading. You'd think temporal bone, right?
Yeah.
But over 80% of that roof isn't temporal bone at all. It's the infratemporal surface of the much deeper, greater wing of the sphenoid bone.
Wow, 80% sphenoid.
Yeah. Only a small bit, posteriorly, is actually temporal bone, going laterally up to the articular eminence of the TMJ. That distinction immediately tells you just how medial and deep this space really is.
And that sphenoid roof It's not solid, is it? It's got these critical doorways connecting straight up into the middle cranial fossa, the foramina.
Exactly. These are the direct pathways, like you said. Pathways for nerves and vessels, but also, critically, for the spread of infection or tumor. You absolutely have to know them.
So what are the key ones up there?
3 main players. The large foramen oval.
Okay.
The smaller foramen spinosum, right near it. And then there's a more variable one. The sphenoid emissary foramen, sometimes called the foramen of Vesalius. These aren't just anatomical names to memorize. They're critical neurovascular choke points.
And if you're coming in from a lateral approach,
Yeah.
say you need to know exactly how deep they are, right, to avoid, well, disaster.
Disaster is the right word. Penetrating the dura, injuring intracranial structures. That's why those specific metrics we found are so vital. They're not just trivia, they're safety gauges.
Okay, so give us the numbers. What are we talking about depth-wise?
So the data shows the average depth, measuring from a reliable external landmark, like the zygomatic root, down to the foramen oval average is about 26.2 millimeters.
Okay, about 26 mil.
Yeah, and the range is pretty tight, 22 to 29 millimeters. Then going slightly deeper to the foramen spinosum, it averages 31.7 millimeters with a bit more variation, maybe 25 to 36 mil.
So knowing that, say, 30 millimeter mark is critical if you're drilling near the skull base.
Yeah, absolutely. It tells you you're approaching that critical skull base floor. It's the difference between achieving your surgical goal and causing, potentially lethal harm. These numbers confirm your depth.
All right, moving around the perimeter, the anterior wall. That seems straightforward.
Yeah, that's mostly the posterior wall of the maxilla, extending down to the maxillary tuberosity. But the key connection there is superiorly.
The orbit.
Exactly. It connects directly to the orbit via the inferior orbital fissure, another pathway for things to spread.
Lateral wall.
That's easy. Just the medial surface of the mandibular ramus and the coronoid process. That's your bony lateral limit.
But the medial wall, that sounds like where it gets tricky again, mixing bone and soft tissue.
It does. Anteriorly, you've got bone, the lateral pterygoid plate.
Yeah.
But as you move back posteromedially, the wall becomes soft tissue. It's formed by pharyngeal muscles, the tensor veli palatini and the levator veli palatini, covered by this layer called the pharyngobasilar fascia.
And why is that soft tissue boundary so important?
Because that's what puts you right next to the parapharyngeal space. And that means you're immediately adjacent to the really dangerous stuff, the great vessels of the neck, especially the internal carotid artery. That medial dissection is high stakes.
Speaking of connections, let's talk about the main gateway between the ITF and its medial neighbor, the PPF, the pterygomaxillary fissure.
Ah, yes, the PMF. It really is the crucial communication route. Think of it like the neck of an hourglass connecting the wider ITF laterally to the narrow, deep PPF medially.
So it's literally the gap between the pterygoid plates and the back of the maxilla.
Precisely. And its size can vary quite a bit between individuals.
And that size difference actually matters surgically.
Oh, definitely. Think about a common procedure like a Lefort eye osteotomy, where you need to separate the maxilla from the pterygoid plates. That's called pterygomaxillary disjunction.
Right.
If that fissure is really narrow, making that separation clean is much harder, much riskier. You can get bad fractures or just struggle to get access.
Okay, so it affects orthognathic surgery. What else?
Nerve blocks. If you're trying to do a sphenopalatine ganglion block using a lateral approach, you have to pass your needle through that fissure to reach the ganglion deep inside the PPF.
Ah, see.
So if the fissure's too tight, that lateral route might just not be feasible. You'd have to choose a different way in.
It's fascinating how it all connects.
Yeah.
That point where the inferior orbital fissure running horizontally meets the pterygomaxillary fissure running vertically, it really highlights the PPF as this central hub, doesn't it?
Absolutely. The PPF sits right at that crossroads, connecting the orbit above, the nasopharynx medially, the oral cavity below, the ITF laterally, and the middle cranial fossa posteriorly. Everything funnels through that tiny space.
Okay, so we've mapped the boundaries. Now let's dive into the contents. And this is where it gets really interesting, because surgeons don't just see these structures as obstacles. They use them as precise 3D roadmaps, right?
Exactly. They're your guides. Let's start with the big muscular guides, the muscles of mastication packed in there.
Top of the list has to be the lateral pterygoid.
Yeah, the lateral pterygoid muscle is really the key organizer of the ITF. It runs pretty much horizontally, kind of defining that roof space we talked about.
It has two heads.
Two heads, yep. An upper one from the sphenoid wing and a lower one from the lateral pterygoid plate itself. They merge and insert onto the mandibular condyle and the TMJ capsule, and its relationship to the maxillary artery. That's often the first major anatomical point a surgeon has to figure out during a lateral approach.
Okay, then below that, running more vertically.
That's the medial pterygoid muscle. It also has two heads, a smaller superficial one from the maxillary tuberosity, and a larger deep head from the medial side of the lateral pterygoid plate. It runs down and back to insert on the angle of the mandible.
And these two muscles, the medial pterygoid and the master on the outside, they form this sort of sling for the mandible.
That's exactly right, the pterygomasseteric sling. That sling, plus a couple of important ligaments, the sphenomandibular and the stylomandibular ligaments, they basically control how the mandible rotates and moves.
And surgically, why is knowing about that sling and those ligaments so critical?
Because if you need maximum access to the ITF, say for a really large tumor, you often have to perform what's called a mandibular swing procedure.
Which means?
It means you surgically cut the mandible, usually near the angle, and literally swing it outwards or downwards. But to do that, you have to detach the medial pterygoid from its insertion, release that sling, and often cut those ligaments.
Okay.
Without releasing that whole anchoring mechanism, you simply can't get the jaw out of the way enough to see the deep ITF structures up to the skull base. It's a key step for wide exposure.
Moving slightly back in medial now, we find the pharyngotympanic tube, the eustachian tube. You wouldn't immediately think of it in ITF surgery, but you're saying it's a critical landmark.
Absolutely critical, not for hearing in this context, but for safety. It defines the posteromedial limit of your dissection. If you stay lateral to the tube, you're generally safe.
And what structure are you trying to avoid by staying lateral?
The big one, the extracranial portion of the internal carotid artery, ICA, running in the parapharyngeal space, just deep and posterior to the tube.
Okay.
The tube itself has segments cartilaginous, junctional, bony. Knowing where it runs, especially that cartilaginous part deep to the medial pterygoid plate, helps you locate the ICA and stay away from it. It's a vital safety barrier.
Which brings us neatly to the vasculature. The maxillary artery, the main arterial supply here, but also flagged as a major hazard.
Huge hazard. It's the larger terminal branch of the external carotid artery, and it's big. Its entry point into the ITF is key. It slips in right between the neck of the mandibular condyle and the sphenomandibular ligament.
And the surgical strategy, given its size and variability, early control.
Absolutely. For any significant ITF clearance, standard practice is early identification and ligation of the proximal maxillary artery right near the condyle where it enters.
Why so early?
Because it dramatically reduces bleeding throughout the rest of the procedure. It just makes the whole field cleaner, easier to see, safer to work in. Trying to chase down branches later in a bloody field is much harder and riskier.
And it's variable in its course too, isn't it? Relative to the lateral pterygoid.
Very variable. Sometimes it runs superficial to the lateral pterygoid, sometimes deep. You can't assume. That's another reason why getting control proximally before it starts branching and weaving around the muscle is so important.
Okay, let's break down its three segments. This seems like detail needed for mastery. First part.
The first part is the mandibular segment. It runs deep, usually along the inferior border of the lateral pterygoid. Its key branches here are the inferior alveolar artery.
Following the nerve.
Yep, goes with the IAN into the mandibular foramen, and the middle meningeal artery, MMA.
Ah, the MMA. That goes back up into the skull, right? Tell us more about that one. How soon does it branch off?
Very early. Our sources say it arises, on average, only about 12.2 millimeters from the origin of the maxillary artery itself.
Wow, that's quick.
It is. It then ascends almost immediately, passing between the lateral pterygoid and the tensor veli palatini muscle, and heads straight for the foramen spinosum to enter the cranial cavity and supply the dura mater. It's a major dural supplier.
And there's also an accessory meningeal artery sometimes, the AMA.
Yes, the AMA is variable. Its origin seems to correlate with how the maxillary artery runs. If the maxillary artery is running deep to the lateral pterygoid, the AMA usually comes off the maxillary artery itself. But if the maxillary is running superficial, the AMA often arises from the MMA instead.
Interesting variability, and it enters the skull.
Usually through the foramen oval along with V3, or sometimes through that little foramen of Vesalius. Knowing these variations helps you anticipate where bleeding might come from if you're working near the middle cranial fossa floor.
Okay, segment 2, the pterygoid segment. This is defined by its relationship to the lateral pterygoid muscle.
Exactly. This is the part that's actually running either deep or superficial to the bulk of the lateral pterygoid muscle. It mainly gives off branches to the muscles of mastication, deep temporal branches, masseteric branches, buccal branches. These tend to be smaller, more variable, lots of connections between them.
Got it. And finally, segment 3, the pterygopalatine segment. This one heads medially.
Right. It usually passes between the two heads of the lateral pterygoid muscle, aims for that pterygomaxillary fissure.
The gateway.
The gateway, yes.
Yep.
And enters the Pterygopalatine Fossa, PPF, where it finally terminates into its last set of branches.
And these terminal branches are really important clinically, aren't they?
Hugely important. You get the infraorbital artery, the posterior superior alveolar supplying the upper teeth, the descending palatine, and the big one, the sphenopalatine artery, SPA.
Okay, why is the SBA singled out, especially for endoscopic work?
Two main reasons. First, it's the largest terminal branch and the major blood supply to the nasal cavity. So if you have severe, uncontrollable nosebleeds, refractory epistaxis,
Right.
the SPA is the vessel surgeon's target for ligation. They go in endoscopically, find it near the sphenopalatine foramen by the middle turbinate, and clip it or cauterize it.
Okay, epistaxis control. What's the second reason?
Surgical flaps. Modern endoscopic skull-based surgery relies heavily on reconstructing defects after removing tumors. The Haddad-Basagastegui flap, for example, is a workhorse flap. It uses nasal septal mucosa, and its blood supply is based on the posterior septal branches of the SPA. That reliable vascular axis, that axial pattern, is what makes these flaps survive and allows for really extensive skull-based reconstructions endoscopically. The SPA is fundamental to that.
We should also quickly mention the descending palatine artery in the context of common facial surgery.
Good point. The descending palatine artery runs down in the greater palatine canal in the posterior maxilla. During a standard Laforte osteotomy, where you cut the maxilla horizontally to reposition it, those bone cuts pass right through the area where this artery is running in its canal.
Yeah.
So it's very common to transect it. It's not usually a massive bleeder, but it's a consistent source of bleeding you need to anticipate and manage during that procedure.
Okay, that covers the artery. Now the veins. Maybe the biggest headache in ITF surgery. The pterygoid venous plexus, PVP.
Oh, the PVP. Yeah, headache is a good word. It's not a single vein, but this dense, complex network of veins all wrapped around and within the lateral pterygoid muscle.
And the muscle itself helps pump the blood.
Exactly. When the lateral pterygoid contracts, it squeezes the plexus and helps pump venous blood out. But the real danger isn't just the volume of blood, it's where it connects.
Okay, where does it drain or communicate that makes it such a hazard?
Critically, it has direct connections to the cavernous sinus intracranially.
Wow.
Through emissary veins that pass up through those same foramina we talked about, ovale, lacerum, sometimes basalius. It also connects forward to the orbit via the ophthalmic veins and obviously outwards to the facial veins.
So infection or a clot here could spread directly into the brain or the eye socket.
Very easily. That's the big danger. Surgically, the problem is just troublesome bleeding. It's venous, low pressure, but it's diffuse and high volume because it's a plexus, not a single vessel.
And our sources specifically say diathermy or cautery isn't the best way to handle it. They recommend packing instead.
That's a key tactical point, yeah. The veins are thin-walled, there are tons of them, and they just ooze everywhere when disturbed. Trying to zap each little bleeder with cautery is often futile, takes forever, and you risk hitting nearby nerves like V3 or even getting too close to the ICA.
So packing is better.
Packing with hemostatic gauze, things like Surgicel or Gel foam, is generally preferred. You basically pack the bleeding area firmly, create some pressure, and then you can often move on with the dissection elsewhere while the packing does its job. It's about hemorrhage control, not necessarily definitive stopping of every little vessel right then and there.
And for really extensive tumor removal, what's the radical approach?
For a total ITF clearance, particularly for cancer, the advice is often a complete compartment resection. That means taking out the entire lateral pterygoid muscle, plexus and all, as one block.
Wow.
It ensures you get the whole plexus and any infiltrated tissue rather than trying to pick through it.
Okay, with all these hazards, surgeons obviously rely on safety nets. Let's talk about the stylohamular dissection plane. What is that and how does it help?
This is a really useful concept. It's the plane, or potential space, defined between the styloid process posteriorly and the pterygoid hamulus, which is the little hook off the medial pterygoid plate, anteriorly.
And its purpose?
It serves as a surgical guide, a landmark for the medial boundary of the ITF during a lateral approach. It helps the surgeon know how far medially they can safely go before getting into the parapharyngeal space proper.
So how do you use it practically?
You identify the styloid process, maybe by feel or direct vision, and then dissect carefully in that plane towards the hamulus. The absolute crucial safety point here is that the internal carotid artery, ICA, lies deep or medial to this plane.
Ah, so the plane protects the ICA.
Exactly. By staying lateral to or within that stylohamular plane during your lateral ITF dissection, you are keeping the ICA safely shielded behind the structures that form the post-styloid compartment. It's like an anatomical firewall. So we've mapped the space, identified the big vascular hazards. Now we get to the structures that really let you navigate this complex terrain safely.
The nerves. These are your internal GPS.
Right, the road maps. Starting with the big one, the mandibular nerve, V3, largest division of the trigeminal, exits the skull through.
Foramen oval, that doorway in the roof we talked about. It carries both sensory and motor fibers.
And as soon as it exits, where is it sitting?
It's immediately lateral to the tensor veli palatini muscle, and it's deep, maybe about 4 centimeters in from the neck of the mandibular condyle. The undivided trunk itself is quite short before it branches.
What comes off that main trunk right away?
The main thing is the nerve to medial pterygoid. As the name suggests, it supplies the medial pterygoid muscle, but also, importantly, those small muscles, tensor veli palatini and tensor tympani. And we mentioned the otic ganglion earlier. There's a connection here, right?
Yes. The nerve to medial pterygoid actually passes directly through the otic ganglion. But, and this is a key point, it does so without synapsing.
Just passing through.
Just passing through. The motor fibers stay motor fibers. The ganglion itself is functionally separate, related to parasympathetics for the parotid gland, which we'll get to, but V3's branch just uses it as a pathway.
Okay, so after that short trunk, V3 splits.
Right. It quickly divides into an anterior and a posterior division. The anterior division is mostly motor.
Supplying.
The other main muscles of mastication, temporalis, masseter, and the lateral pterygoid. But it does have one significant sensory branch,
Which is?
the long buccal nerve. This one runs forward and laterally, often actually piercing between the two heads of the lateral pterygoid muscle, and emerges near the front edge of the mandibular ramus to supply sensation to the cheek, mucosa, and skin.
And surgically, why do we care about the buccal nerve?
Well, its location makes it a common landmark for giving local anesthetic, like a dental block. But it's also quite vulnerable during surgery near the anterior border of the ramus, or if you're dissecting in the buccal fat pad area, cut it and the patient gets numbness in the cheek.
Okay, that's the anterior division. The posterior division, this is where our main sensory roadmap nerves come from.
Exactly. The posterior division is much larger and mostly sensory, though it carries some motor fibers too. It gives rise to the lingual nerve, the inferior alveolar nerve, and the auriculotemporal nerve.
And the length of this division before it splits is variable.
Highly variable. The average length before it bifurcates into the lingual and inferior alveolar nerves is about 13.5 millimeters, but the range in the literature is huge, like 6 to 32 millimeters.
So you can't just measure down a set distance and expect to find the split.
No, definitely not. You have to actually identify the nerves themselves.
Okay, let's focus on the two big ones used for navigation. First, the inferior alveolar nerve, IAN.
The ANN is the largest branch off the posterior division. It runs downwards and a bit laterally, tucking in between the sphenomandibular ligament medially and the mandibular ramus laterally, heading for the mandibular foramen to enter the jawbone.
Supplying the lower teeth and lip sensation eventually. Does it have any motor component?
Just one branch, given off before it enters the foramen, the nerve to mylohyoid. This supplies the mylohyoid muscle, the floor of the mouth, and the anterior belly of the digastric muscle.
Okay. And running sort of parallel and usually anterior to the AAN is the lingual nerve.
That's right. The lingual nerve descends medial to the lateral pterygoid, between it and the tensor veli palatini, usually lying anterior and slightly medial to the AN within that pterygomandibular space.
And it picks up a hitchhiker, doesn't it? The chorda tympani.
It does. The chorda tympani, which is actually a branch of the facial nerve, CN7, joins the lingual nerve high up in the ITF. The data suggests this junction happens, on average, about 8.4 millimeters from where the lingual nerve originates from V3.
And the chorda tympani carries.
Cased fibers from the anterior two-thirds of the tongue, and also those important preganglionic parasympathetic fibers destined for the submandibular and sublingual salivary glands. So damage to the lingual nerve high up affects taste and salivation, not just tongue sensation.
Okay, here's the payoff. How do surgeons actually use the IN and lingual nerve as this roadmap strategy for complex ITF surgery, like getting up to the skull base?
Our sources call them excellent roadmaps because they provide a direct, reliable path. The strategy is this. You identify these two nerves deep in the surgical field, the IAN heading towards the mandibular foramen, the lingual nerve usually visible near the mandibular third molar region medially.
Got them identified. Then what?
Then you dissect along their lateral aspect. You essentially follow them upwards and backwards. This path requires you to transect or retract the lateral pterygoid muscle.
Okay.
But by staying on the lateral side of those nerves and following them superiorly, they lead you directly and reliably to the foramen ovale, where V3 exits, and the lateral pterygoid pleat area right at the roof of the ITF, the skull base.
So they're like anatomical guide rails taking you straight to the target foramina.
Exactly. Guide rails is a perfect analogy. And there's one surgical maneuver that makes following these guide rails much easier.
Let me guess. Removing the coronoid process.
You got it. An early coronoidectomy, removing that pointy part of the mandible where the temporalis muscle attaches, significantly improves your access and visibility. It relaxes the temporalis pole and just opens up that deep space, making it much easier to find the nerves and follow them safely up to the skull base. It simplifies the dissection considerably.
Makes sense. Lastly, for this section, let's just quickly revisit the audit ganglion. We know the nerve to medial pterygoid passes through it.
Yeah.
What's its actual function?
The audit ganglion itself is a tiny parasympathetic relay station. It sits just below the foramen oval, tucked medial to the V3 trunk and lateral to the tensor veli palatini muscle.
And it controls.
Its job is secretomotor supply to the parotid gland making saliva. The preganglionic parasympathetic fibers arrive via the lesser petrosal nerve, which is a branch of the glossopharyngeal nerve, CNIX. They synapse in the audit ganglion, and the postganglionic fibers then hop onto the auriculotemporal nerve, another V3 branch, to reach the parotid. It's a small but functionally important little hub right there at the skull base.
Okay, we've thoroughly explored the lateral space, the ITF. Now we transition medially, slipping through that gateway, the pterygomaxillary fissure, into the Pterygopalatine Fossa, PPF. This sounds even more complex, the deep neural hub, the real crossroads.
It really is. If the ITF is a complex junction, the PPF is Grand Central Station. Anatomically, it's described as a small, inverted, pyramidal space. Think of a tiny pyramid with its base up against the skull base and its apex pointing down towards the palate.
And location-wise, deep and central.
Very deep, very central. It's tucked away below the apex of the orbit, medial to the ITF, which we just left, lateral to the upper part of the nasal cavity and nasopharynx, and anterior to the pterygoid plates.
Let's lock down its boundaries. It's small, so it gets to be tight. Roof and posterior wall.
The roof is formed by the body of the sphenoid bone. The posterior boundary is quite solid. It's the root of the pterygoid process and the anterior surface of the greater wing of the sphenoid.
Anterior boundary.
That's the posterior wall of the maxilla, specifically the supramedial part of it.
And the medial wall is what separates it from the nasal cavity.
Correct. That's the perpendicular plate of the palatine bone. And importantly, that medial wall contains the sphenopalatine foramen, the main gateway into the nasal cavity.
And the lateral boundary is just that opening we came through.
Exactly. The lateral boundary is the pterygomaxillary fissure, the opening connecting it back to the ITF.
Okay, given this central location, it must communicate with practically everywhere. These are the potential escape routes for disease, right?
You absolutely have to know these connections cold. They explain how pathology spreads so easily from here. So going posteriorly, it connects straight into the middle cranial fossa via two key openings, foramen rotundum,
Carrying V2.
carrying the maxillary nerve, V2, yes, and the pterygoid canal, also known as the Vidian canal, carrying the Vidian nerve and vessels.
Okay, medial connection.
Medially, through that sphenopalatine foramen, it opens directly into the nasopharynx and posterior nasal cavity.
Inferiorly.
Inferiorly, the greater palatine canal runs down from the apex of the fossa into the oral cavity onto the hard palate.
And superiorly.
Superiorly, the medial end of the inferior orbital fissure opens directly into the orbit. So you've got connections to the brain, nose, mouth, orbit, and the ITF. Everything meets here.
Wow. Okay, to try and simplify this incredibly packed space, our source material uses a helpful concept dividing the PPF content into two compartments.
Yeah, this is a really useful surgical distinction. It helps you anticipate what you'll encounter where. They divide it into an anterior compartment and a posterior compartment.
What's in each?
The anterior compartment is primarily vascular. That's where the terminal part of the maxillary artery and its final branches, like the sphenopalatine, are located.
Okay, vessels up front.
Vessels up front. The posterior compartment is primarily neural. This is where you find the pterygopalatine ganglion self, the maxillary nerve V2 trunk as it enters from foramen rotundum, and the vidian nerve coming in posteriorly.
So surgically, you expect to deal with vessels first, then nerves deeper in.
Generally, yes, especially with endoscopic approaches coming often from anterior or medial. You manage the vascular elements in the anterior part to get clear access to the neural structure sitting more posteriorly. It's a predictable layout.
Let's zoom in on that neural hub then, the pterygopalatine ganglion, PPG, the ganglion of hay fever.
Haha, yes, that's its nickname because it's the main relay station for parasympathetic nerves that make your nose run and eyes water. It's the largest parasympathetic ganglion associated with the cranial nerves.
And its main job is?
Secretomotor supply, telling the glands in the nasal mucosa, sinuses, palate, and lacrimal gland to produce secretions.
Where do its input fibers come from? This involves the vidian nerve, right?
It does. The functional anatomy is key. The preganglionic parasympathetic fibers actually start with the facial nerve, CN7, traveling in its greater petrosal nerve branch.
Okay.
This nerve then joins up with the deep petrosal nerve, which carries postganglionic sympathetic fibers that have traveled up along the internal carotid artery plexus.
So parasympathetic meets sympathetic.
And they join forces to form the vidian nerve, also called the nerve of the pterygoid canal. This composite nerve then travels through the pterygoid canal in the sphenoid bone to reach the PPG in the posterior compartment.
So the vidian nerve is actually carrying both types of autonomic fibers.
Exactly. It's a mixed autonomic nerve. When it reaches the PPG, only the parasympathetic fibers synapse there. The sympathetic fibers just pass straight through, heading for the target tissues. But knowing the vidian nerve contains both is important, and crucially for surgeons, tracking it leads you somewhere very important, as we'll see.
Okay. The other major neural player here is the maxillary nerve, V2 itself.
Right. V2 is purely sensory, remember. It exits the middle cranial fossa through foramen rotundum and enters the PPF superiorly and posteriorly. All of its extracranial branches, the ones supplying the midface, arise within this tiny fossa.
What are the main branches coming off V2 here?
It gives off the zygomatic nerve, supplying the cheekbone area, the posterior superior alveolar nerves to the upper molar teeth and max sinus, and then continues forward as the infraorbital nerve, ION.
And the infraorbital nerve gets the title of the critical PPF landmark. Why is its short path through the PPF so vital for navigation?
Because it's the largest, most identifiable branch of V2 in the fossa. It runs laterally across the roof of the PPF for a very consistent, measurable distance. The average is 13 millimeters, plus or minus about 2.5 millimeters, before it ducks into the orbit through the inferior orbital fissure.
13 millimeters. That's precise. And how does that help a surgeon?
It serves two critical navigational roles. First, its path clearly demarcates the PPF medially from the ITF laterally, right at the level of the inferior orbital fissure. It's the dividing line. Second, and more importantly for deep dissection, you can identify the ION and trace it posteriorly. Following it backwards leads you directly to its origin from V2 and therefore points you straight toward the foramen rotundum. It's the neural pathway leading back to the middle cranial fossa entrance. It's your guide back home, anatomically speaking. So if we bring all this anatomy together, ITF, PPF, nerves, vessels, compartments, it becomes clear that successful, safe surgery in this neighborhood depends entirely on disciplined application. Knowing the landmarks, knowing the hazards, knowing the do's and don'ts, absolutely cold.
Let's focus on those modern endoscopic techniques for accessing the PPF, often coming through the nose. How do surgeons use those nerve and artery relationships, particularly the vidian nerve and the ICA, to avoid absolute catastrophe?
Right, this is high-stakes navigation. Typically, an endoscopic approach, say for a tumor in the PPF, starts with managing the vasculature anteriorly, usually identifying and ligating the sphenopalatine vessels near the foramen.
Clear the decks first.
Clear the decks. Once you have hemostasis and the fossa is opened up, the next step is often to identify the neural structures posteriorly. You find the pterygopalatine ganglion.
Okay.
Then, by carefully tracing the ganglion medially and slightly posteriorly, you can identify the vidian nerve entering the fossa. Now, here's the critical part. You follow that vidian nerve backwards, towards the skull base where it came from.
And where does it lead?
The vidian canal acts like a laser pointer aimed directly at the second genu of the internal carotid artery.
The second genu. That's the bend where the ICA turns forward in the cavernous sinus.
Exactly, the horizontal cavernous segment. Following the Vidian canal is one of the most reliable ways to locate that segment of the ICA endoscopically.
Okay, that's the second genu.
Right.
What about the first genu, the bend lower down where the ICA enters the skull? Is there a landmark for that too?
There is, and it brings back our friend the pharyngotympanic tube, PTT. Remember we said it was a landmark for the ICA and the ITF parapharyngeal space? Yeah. Well, if you follow the cartilaginous PTT posteriorly to where it transitions into its bony canal near the skull base, the first genu of the ICA, the posterior bend of the petrous segment, lies just posterior to that junction.
So two key relationships for finding the ICA endoscopically. Vidian canal points to the second genu. PTT junction points to the first genu.
Precisely. These are absolute, non-negotiable anatomical coordinates for locating the ICA from an endoscopic view. If you get disoriented deep in the skull base, you retreat and find one of these landmarks to reorient yourself relative to the carotid.
It sounds like you absolutely cannot rely just on looking around. You need these guides.
You cannot, which is why intraoperative navigation systems, using pre-op CT MRI scans and sometimes microdoppler ultrasound probes, are considered essential safety tools for these advanced endoscopic skull-based procedures. They help confirm you've correctly identified the ICA before you proceed with dissection nearby. You need that technological backup.
Okay, so we have two distinct sets of navigational roadmaps. Let's just recap them clearly for everyone trying to master this.
Good idea. For navigating the lateral space, the infratemporal fossa, ITF, your primary neural guides are the lingual nerve and the inferior alveolar nerve, IAN. Follow them upwards.
Okay, ITF, lingual, and EN. For the deep medial space, the Pterygopalatine Fossa, PPF.
For the PPF, your key neural guides are the infororbital nerve, ION, tracking back to foramen rotundum, and the Vidian nerve, tracking back towards the ICA and pterygoid canal.
PPF, ION, and Vidian. Got it. And if you're looking down from above, like a neurosurgeon, there's that arcata foramina.
Yes. Looking at the floor of the middle cranial fossa, the foramen rotundum anteriorly, and then the foramina oval and spinosum more posteriorly, they form a predictable arc or line.
And that helps define.
That arcade defines the medial boundary where the cranial fossa ends and the ITF-PPF begins below. It's a critical landmark for superior intracranial approaches to prevent inadvertently dropping down into the fossa too early or in the wrong place.
All right, time for the scary part. Let's consolidate the absolute, non-negotiable hazard list, the critical do-nots for anyone operating here.
Okay, hazard list. In the ITF, the immediate vascular risks are the high-flow maxillary artery, and lurking medially and posteriorly, the internal carotid artery.
Neural risks in the ITF.
Injury to the lingual nerve or the inferior alveolar nerve. Damage here means permanent numbness, potentially altered taste, or issues with the floor of mouth muscles, significant morbidity.
And the procedural nuisance hazard.
The unpredictable, often hard-to-control bleeding from the pterygoid venous plexus. It won't kill you like hitting the ICO, but it can obscure the field and make the surgery much more difficult and risky.
Okay, moving medially to the PPF. What are the top hazards there?
In the PPF, the vascular risks are the terminal branches, especially the sphenopalatine artery, significant bleeding potential if uncontrolled, and again, the ever-present internal carotid artery, particularly its relationship to the Vidian canal posteriorly.
Neural hazards in the PPF.
The main trunk of the maxillary nerve, V2 itself, as it comes through foramen rotundum, and its major branch, the infraorbital nerve, ION. Damage here leads to midface numbness. Remember the compartments. Vessels anterior, nerves posterior.
And the final hazard, which makes these areas particularly concerning for cancer patients, perineural spread.
Yes, this is a huge issue here. Because the PPF and ITF are crossroads for major branches of the trigeminal nerve, V2 and V3, tumors, especially certain types like adenoid cystic carcinoma or squamous cell carcinoma, love to use these nerves as highways.
Traveling along the nerve sheath.
Exactly. The tumor cells track along the perineural space, often silently extending far beyond the visible tumor mass, right up along V2 or V3 towards the foramina, rotundum, oval, and into the skull base, potentially reaching the cavernous sinus or brainstem. It's an insidious and dangerous pattern of spread that makes complete removal very challenging.
Okay, we've built the map, highlighted the dangers. Let's put it all together with a real-world clinical scenario, a challenging case. A mandibular nerve schwannoma, our patient. A 46-year-old woman. Her symptoms are ear discomfort, a feeling of a lump in her throat, and crucially, a persistent tingling sensation in her lower lip and chin.
Right away, that last symptom, the paresthesia in the lower lip and chin, is the diagnostic bullseye.
Why specifically?
Because that's the exact sensory distribution of the mental nerve. And the mental nerve is the terminal cutaneous branch of the inferior alveolar nerve, IAN.
Which comes from?
Which comes from the mandibular nerve, V3. So that one symptom immediately tells you the problem involves V3, or its ENN branch, somewhere along its path from the skull base down towards the mandible, likely within the ITF.
Okay. Clinical localization points straight to V3IN. The physical exam confirms reduced sensation there and also finds a smooth mass bulging in the lateral pharyngeal wall, confirming it's deep. Now, imaging. The OPG, the panoramic dental X-ray, showed something critical.
Yes, the OPG showed enlargement of the inferior dental canal on the symptomatic side when compared to the normal side.
And why is canal enlargement significant?
Because the INN runs within that bony canal in the mandible. If the canal is widened or expanded, it strongly suggests a slow-growing, benign, encapsulated tumor originating from the nerve itself, like a schwannoma or neurofibroma. It's pushing the bone aside gradually, remodeling it, rather than aggressively destroying it like a malignant tumor would.
Clever detective work from simple X-ray. Then the MRI gave the full picture. Coronal views showed.
Coronal MRI confirmed it was a well-defined mass and, crucially, showed it extending all the way from high up near the middle cranial fossa, likely near foramen oval, where V3 exits right down through the skull base, through the ITF, and bulging into the parapharyngeal space near the floor of the mouth. That huge vertical extent explains the throat lump sensation and the ear symptoms due to mass effect.
And the axial MRI views really nailed the origin by showing its relationship to the ITF muscles. This is where knowing that anatomy pays off. What specific displacements did they see?
This was classic. The mass was seen pushing the lateral pterygoid muscle medially and pushing the medial pterygoid muscle laterally.
Splaying them apart.
Exactly, splaying them apart. This pattern confirms the tumor is growing between those two muscles, right in the heart of the ITF, consistent with an origin from V3 or one of its main branches running between them.
Any other mass effects noted?
Yes, it was also compressing the pharyngotympanic tube, PTT, on that side, which wasn't visualized properly. And this compression led to fluid buildup in the mastoid air cells behind the eardrum, which neatly explains her ear discomfort symptoms.
And the million-dollar question, the internal carotid artery.
The MRI confirmed the ICA was located safely posterior to the mass and, importantly, was not displaced or encased by the tumor. That's a huge relief from a surgical planning perspective. So all the findings together, the specific sensory deficit, the canal expansion, the characteristic muscle displacement, the well-defined nature strongly pointed to a mandibular nerve schwannoma.
Okay, diagnosis made. Planning the surgery requires understanding the deep neck spaces, specifically the compartments defined by the styloid apparatus, right?
Absolutely. The styloid process and the muscles ligaments attached to it act as a curtain, dividing the deep parapharyngeal space, which lies medial to the ITF, into two crucial compartments, prestyloid and poststyloid.
And given this tumor arises from the mandibular nerve, V3, which compartment must it be in?
It has to be in the prestyloid compartment. V3 and its branches run in the ITF, which is effectively the lateral part of the prestyloid space. Other things typically found here are the deep lobe of the parotid gland, maybe some lymph nodes, fat.
And the poststyloid compartment contains...
That's the high rent district. The poststyloid compartment, lying behind the styloid curtain, contains the internal carotid artery, the internal jugular vein, and cranial nerves, phi-X, glossopharyngeal, X vagus, salivin accessory, and 12 hypoglossal. All the really critical neurovascular structures.
So, knowing the tumor is prestyloid tells the surgeon they can likely approach it without having to routinely expose those vital poststyloid structures.
Exactly. It dictates the surgical strategy. For a large prestyloid schwannoma like this, originating high up, the typical approach would likely be transcervical coming in from the neck, possibly combined with a mandibular osteotomy or swing.
Right, cutting the jaw.
Cutting the jaw to get wide access to the prestyloid space and follow the tumor safely up towards the skull base, while respecting that fascial plane, separating it from the poststyloid contents. The anatomy dictates the entire surgical plan. #tag outro.
So we've really taken a deep dive today, haven't we? Navigated two of the most anatomically packed, surgically demanding regions in the entire head neck. We defined the spaces, identified the key landmarks, PTT, Vidian nerve, the foramina, and stressed the absolute importance of knowing those neural roadmaps.
Yeah, differentiating the ITF guides the INN and lingual nerves from the PPF guides the ION and Vidian nerve. Right. And we've emphasized the hazards controlling that maxillary artery early, respecting the stylohamular plane to protect the ICA, understanding the venous plexus, and compartmentalizing the PPF into its vascular front and neural back. Mastery here really means internalizing all those details, visualizing it in 3D, and using that map to guide every move.
And we saw vividly in that schwannoma case how pathology uses these very nerve pathways, these roadmaps, to spread, often paraneurally, which leads to a final thought for you to ponder. Thinking about those connections, those foramina in the skull base, arcade rotundum, ovale, spinosum. If a tumor uses the purely sensory maxillary nerve, V2, to spread intracranially through foramen rotundum, how might its pattern of dural involvement or cavernous sinus invasion differ from a tumor that uses the mixed motor and sensory mandibular nerve, V3, spreading through foramen ovale? Their slightly different locations and relationships within the middle cranial fossa change the potential spread patterns entirely. That kind of detailed, predictive anatomical thinking. Well, that's the essence of the continuing deep dive.